All right, good afternoon, everyone. This is the first PNQIN Perinatal Mental Health Bundle webinar of 2025. So thanks for being here today after a long weekend. We've got a great agenda for you, so we're going to go ahead and get started as people trickle in. Please type your name and institution into the chat for attendance purposes. And our optional share for this month is we'd love to hear what is one thing you're hoping to do more of in 2025. As a reminder, please mute yourselves when not speaking, and feel free to type any questions you have for our presenters into the chat during the webinar, and we'll address as many as we can during Q&A at the end. And as always, this webinar is being recorded and will be uploaded with slides to our website within the week. So we have a great agenda for you today. After I give you our monthly announcements, we'll hear from Dr. Ron Iverson, one of our PNQIN OB co-chairs. He'll be giving a little quality improvement refresher for all of you who may be a little fuzzy on your QI terms and strategies. So we're excited to bring that to you today. And then Dr. Uruj Kamal, the medical director for MCPAP for Moms, will be on to walk us through PMHC assessment and illness severity. As a reminder, these are our participating teams. Thank you to all who are here today and who join these webinars regularly. We're so happy to have your participation in this important bundle. And this is a reminder of our participation requirements. So to be implementing this bundle, we ask that you do our onboarding process, submit monthly data, and attend these monthly webinars. Share your feedback with us, which I'll speak to more in a moment. And as always, be thinking about sustainability of your work, which Dr. Iverson will touch on in his presentation. And as always, we thank our extensive PMHC bundle advisory work group who helps to inform the topics of these webinars and the resources that we provide to help you all with your bundle projects. Okay. So a couple of PNQIN announcements. The first and perhaps biggest is that PNQIN has decided to extend the implementation of the Perinatal Mental Health Conditions bundle. So you may remember that we initially planned for 12 months of this bundle, but based on some early feedback from hospital teams, we felt it would be helpful to extend it to 18 months. So instead of wrapping things up this September, we'll be looking to do that now instead a year from now in February 2026. Monthly webinars and data submission will continue during these additional months, and we look forward to continuing to provide support as you complete your projects over this time. Like I just mentioned, the bundle implementation feedback survey is coming out soon. This is a requirement for participating in the bundle. The survey will be open during the month of February, and there will be several questions asking for your team's feedback on how the bundle's going so far, including any challenges you may be facing, so that PNQIN can reach out individually and just provide some more tailored support. As to who should complete this survey, we ask that at the very least, your OB or nursing champion and your ambulatory champion, if you have one, complete this survey. However, anyone on your bundle team can submit a response. We welcome any and all feedback, which is very valuable to us. So we look forward to hearing from you in February. For any of you who weren't able to join us at the PNQIN Summit in December, we are so excited to announce that we've brought on 3 people for our PNQIN Patient and Family Advisory Council. So their names and faces will become more familiar to you as time goes on, but we're so excited to have Jira, Andrea, and Jessica as part of the PNQIN leadership team, and to use their lived experience to help inform patient integration into what PNQIN does more widely. So we'll have more updates to come as they get settled. The neonatal arm of PNQIN, NeoQuick, is having an in-person meeting on February 12th. The first part of the day from 9 a.m. to 2 p.m. will be the meeting of the Respiratory Care Collaborative, and from 2:25 to 4 p.m. will be the Budding Tiny Baby Collaborative, so the care of 22 to 24 weekers. This meeting is in person in Waltham, but there will be a virtual attendance option available. The agendas and registration link are here on the slide. And if Brooke's Wi-Fi is cooperating today, she'll be putting links to these events and announcements in the chat for you all. All right, a couple announcements on the state level. MCPAP for Moms is having a webinar on postpartum psychosis next Thursday on the 30th. Dr. Uruj Kamal Haider, who is speaking on our webinar today, will discuss 4 high-yield clinical cases on postpartum psychosis and walk attendees through diagnostic formulation and management. So if that is of interest or relevance to your work, please tune in next Thursday. The MGH Center for Women's Mental Health has started a podcast called So Glad You Asked, and they are now looking for real moms and birthing people to join season 1 of the podcast. So if you know of anyone who would be interested in asking their questions of the podcast hosts or being part of this project, please share the application with them. We'll be emailing the application out after this webinar, and applications will be accepted until the end of this month. The MASPER TTA is having another cohort of their motivational interviewing virtual course. It's a 5-week intensive course on motivational interviewing foundations and strategies. It is virtual, and it will begin on February 24th, going to the end of March. So you can expect to spend 4 to 5 hours of your time per week in this course, and the links to read the full training description and to apply are on the slide. The Massachusetts Perinatal Team, MAPT, is looking for new members. So MAPT is a consortium of Massachusetts perinatal nurse leaders, managers, and educators. They meet every month on the 3rd Friday, usually virtually, but sometimes in person, from 11 a.m. to 1 p.m. They are a wonderful group. They've been around even longer than PNQIN, but do much of the same work, and there's a lot of crossover. So if you're interested in joining this group or learning more about what they do and discuss, please feel free to email them at massperinatalteam@gmail.com. MCPAP for Moms is also available for general education opportunities. So they have spoken on these webinars previously, including in just a few moments, but they are available to come to your hospital for grand rounds. So if that is something that you're interested in for your providers and staff, feel free to email Beth McGinn. Her email is listed on this slide, and they would love to work with you to plan an event. We're excited to share that there's been a new memorandum on maternal screening from MassDPH. This memorandum provides guidance for healthcare providers treating pregnant people and newborns on screening for mental health and substance use disorders and connections to treatment as appropriate. We'll be distributing the full guidelines of this memorandum after the webinar. The PCORI grant, working in Massachusetts to help OB practices integrate obstetric and mental health care, is still looking for some Massachusetts practices to participate in this study. All participating practices will receive almost $40,000 in funding across 4 years of involvement. So if this is something that interests you as part of your work on this bundle, please feel free to reach out to Dr. Nancy Byatt, whose email is listed on this slide as well. Lastly, from the state, if you are planning or already have a hospital-based doula program, DPH wants to connect with you to learn about it. Please reach out to Adriana Jean Lewis. She'd appreciate the opportunity to connect with your system to learn what you're planning or what you have in place. Before I turn it over to Dr. Iverson, just a few national announcements. Those of you familiar with the Institute for Perinatal Quality Improvement, they're having their annual 28-day anti-racism challenge this February. They update the content of the challenge every other year. So this is version 3, all new content, all new prompts. This is a fantastic way to build on any learning or reflections that you may have done yesterday as part of Dr. Martin Luther King Jr. Day. It's a daily email prompt with education and opportunities to provide insight and support for your anti-racism journey. There is a new cohort for the community of learning on lived experience integration. This community program is brought to you by Mama's Voices and AIM. This is a 4-week program designed to help providers better integrate patients and families into quality improvement, and the cohort will run weekly from February 26th to March 19th. So you can click on the link on this slide to register. And finally, we're thrilled to share that the new book, Ripples of Hope in the Mississippi Delta, is now available. Those of you, again, who know PQI or Deborah Bingham, she helped to finish this book, which was written by her son, who tragically passed away 3 years ago. This is a culmination of her son David's work in the South on health equity. So it's a wonderful read, and be sure to pick up a copy. And with that, I am so thrilled to turn it over to Dr. Iverson for our quality improvement refresher. Thank you all.
All right. Thank you, Kaylee, excuse me. That was an amazing number of announcements. And I was thinking it would be exhausting to try to do even a few of those. But I hope that people take up some of those offers. And particularly, I really like the Mama's Voices project. Well, really, whatever you need, please try to pick up and do. We have so many great collaborating teams. This presentation actually is a response to our team's surveys from this last summer. So we're really glad to be able to talk just a little bit about quality improvement or process improvement, however you want to talk about it, and just give you a little refresher on terms, how to do it. I'm always thinking about how to apply these processes to the work we do. And I would say, don't just save this for the big stuff. Start doing it on smaller things that you're trying to implement or work on or improve, or questions you're trying to answer in your space, and then go bigger. Next, please. So what we do here is we're going to talk about the model for improvement, which is developed by the Institute for Healthcare Improvement, or IHI, which is really a sort of an amalgam or a process that's developed from Lean and Six Sigma and other process improvement from the engineering world. And so this is really meant to help us in the healthcare space, but those other tools are also incredibly valuable. So if that's what you want to do, we all are working generally in the same way with all these different process improvement models. So with this model that we're going to talk about, the model for improvement, our first goal is to think about what are we trying to accomplish? What problem are we trying to solve? What question are we trying to answer? What are we trying to implement? What new tool, for example? We want to think about what we want to know when that change is actually an improvement. So we're always able to make change. That's not that hard. But when is it actually an improvement in the care we're providing and the experience our patients are having and the people who work there are having as well? What changes can we make that result in that improvement is the big question. And then how do we get those changes actually to stick when we want them to, and to continue to be the way we do it, the way we've always done it? Next, please. So when we think about this, we're going to go through fairly quickly, and we'll supply these slides to you, no problem, if you would like, to really think about who's on our team, how do we look at data as we get started in an ongoing fashion, how do we think about the policies and procedures that we have, remembering that procedures aren't just things that are defined in policies, but the way we do things, like the general processes that we have in our day-to-day activities on labor and delivery or in the outpatient space. We want to talk about developing an aim statement or what's our goal, and then ways to break that down, either through a driver diagram or through a more problem-based process through the Ishikawa diagram. And then finally, how do we organize our teams for that change? Again, this is very quick. These courses can take weeks or months as well. But again, I think it's always fun to reflect on what we've done and how we can do it better going forward in wherever we are in the adventure of process improvement in our own spaces. Next, please. First, let's think about our teams. And I think that this is the real key to everything that's going to happen afterwards, is that the right and all the voices be at the team, including patients or people from our community. We want to think about who's in charge, who are our champions. We want to think, using our rough aim statement, what do we think we're trying to solve? Who would be infected? And what systems might be affected by that as we try to make the changes? And they should be at the table. And also really thoughtfully going through who are the change agents, both people who are early adopters and like to move things along quickly, also the cynics. They're really important that we have the people who say, well, this might not work, or did you know if you do this, that'll happen. And to have everybody at the table, again, including our patients, to make these plans for going forward. Next, please. There's a way to think about this with an acronym, of course, and it's the CAST framework. Again, the champions. Who are the individuals or the people who believe in the change, who really might want it to happen? And it's funny because they have on here people from work, but I really think that some of the champions that we should be thinking about is our patients, because the patients often are the ones who will recognize our deficits or needs the best. And to bring patients on as champions can be so valuable, particularly with their real life experience of our care. So the agents, so who are the people who actually make things happen? Who are the managers, the directors who can get the technical changes or the resources into our space? Who are our sponsors? Who from above and around us wants this to happen and can get us the resources we need? And finally, the target. So that's the T. And that is meant to signify the people who actually do the work. So the people at the front desk who might hand out a survey, or the people on labor and delivery who do the actual work. And also the target is our patients. Again, having patients involved is very valuable in a number of ways. Next, please. So I mentioned a couple ways to break down a problem. So we really need to think about, in this case, with driver diagrams, what are the positive things that'll help bring to fruition what we want to happen? And we just used a slide here that is from a driver diagram for substance use disorder screening, SUD screening, really looking at how do we get the screening done and a patient to an OB social worker for an appropriate referral. And this work was done by the folks at the Brigham, I believe, and it was written up by Catherine Callahan at UMass. So together they did this. The driver diagram brings out real nicely, actually, what is the aim? And in this case, they give a date by which they would like to have their project goal met, which is the outcome measure. And they next go through the drivers. So what are the primary drivers? First, you need to have a screening tool. So the NIDA screen is the one that they were using. You need to have it done in a timely fashion and the results brought back. And then finally, you have to be able to generate a response so that people are incented to do this work, because they know that if they have a positive screen, then they can safely continue the patient's care immediately within their space. And then the secondary drivers are noted after that. And then finally on the right, we can see the change concepts. So the change concepts are where people tend to start to lead, people will walk into your office and say, we need to do this. And that's very important and incredibly helpful, but really thinking about how those change concepts, the things that we want to do, fit into the larger goals of what actually will help things get to the final aim or the outcome that we want. Next, please. In this situation, we're looking at an Ishikawa or fishbone diagram, and these are really very helpful when we have a specific problem that we want to solve. So if the problem is patients don't get their screens, then we can start to think about why. And we break it down first by category. So we can look at materials, we can look at methods, we can look at the equipment, the environment, and also the people are the general categories, but you can have others, and try to break it down in those different ways. Once you have your category, then you can look at the specific problems within that category. So let's just say one of the problems is, again, with materials, we don't have enough screens available because our copier doesn't work. So there are a number of things that we can identify within a particular category as barriers to providing the care that is appropriate and safe. So once we do that, we have a cause, and then we can start to think of our change concepts. Again, it comes down to change concepts. Next, please. Part of understanding our problem is looking at the data. Next, please. You can look at the data in a very large way as like the whole population, or it's very important then to break it down into subgroups. So you can do the subgroups based on the various way that patients are identified. We can do age, we can do race, ethnicity, we can do ability. There are so many ways to stratify, and the team needs to think about how we want to stratify our data so that important groups of people are not lost in the larger data categorization. We can use histograms to look at frequency, and we can also try to look at variance with scatter diagrams or other tools. Next, please. In this case, we're looking at, this was an EKG turnaround time, but let's just think about screening turnaround time. So you could, if you had a system that had a lot of variance, say, how long does it take for a screen to be acted upon? Is it 1 to 2 days or 19 to 20 days? Or if your system's got a little bit less variance and you're doing better, you could do number of hours. So you could break this down however you want, but this is a really great way to understand the volume of the problem you have and also to understand something around the variance. Next, please. You can see here on this scatter diagram, you can use whatever variables you want on the X and Y axis to see how one thing affects the other. So you could, for example, put day of the week on the bottom. So what percent of the days, what percent of the time on Mondays do we screen for substance use disorder at the first visit? And you can run that across. I can almost guarantee you that you will have variation. If you don't, that's great. Hopefully your screening level is high and it stays high, but it might be low and not rise. But the point being, you can put different variables on this to really understand how much variance you have based on your different variables. Next, please. How do we prioritize our interventions? This is the fun part. Next, please. Once we get together and we've done our driver diagrams and or Ishikawa diagrams and looked at the data, then the real work for our team comes together. So we have that group of people who have various interests and understandings and knowledge, and we all need to sit together at that point and think about what we want to do next. Here are some of the considerations that are generally thought about. First is cost. How much people time does this take? How much actual physical time does it take? And do we have the ability to do it in the space that we have right now? What equipment do we need? What about safety? So some things that we do have not a huge effect on safety. But what about a screening question that says something to the effect of, I feel like I might hurt myself today or hurt somebody today. So that's a major safety issue. So when we're thinking about the interventions, people really should be focused on what is the safety or danger of what we're looking at doing and trying to solve. Are there other projects that might either hinder or augment the work we're doing? So for example, if you just did a big project on improving screening for SUD a few years ago, and now we say we'd like to screen for perinatal mental health, maybe those two can be combined. But maybe there's something else that's going on in the department or in the space that really will get in the way of this new project. Buy-in. Do people want to do it? Is this just one or two people out of many who think this is a great idea? Or is this a general idea that's been brought to you by the team? Can you pilot PDSA quickly? So can we start to do things quickly and easily, or is everything about what we're talking about with this particular change concept hard and going to take a while? So as we think about this as a team, about how we want to organize our work for the next umpteen days, weeks, months, or a year, then we need to think about all these different things and really understand what are the important components about how people are wanting to organize the work. Next, please. One of the ways to organize ourselves towards this is to look at a prioritization matrix. And so you can see here that this team thought that with the impact and the ease of implementation, they were able to say that, wow, we could do something that's easy and probably not much impact, is to print some screening tools and leave them at the front desk. I think we can all see why that probably won't improve the final goal of getting patients appropriately screened and linked to care. And you can read the other options here to see what might be harder to do, but have low impact or have high impact, for example. Next, please. A lot of the time as we're doing this, I like to use a food algorithm because I love cooking, I love eating. I always try to think about, when we're in the house and we're thinking, hey, let's make tacos, there are a whole number of things that have to happen to finally come together at the right time. And that's the same thing as a project. Some things need to be started and they might take a little bit of time and energy over here on the corner. Some things need to be quickly done and pushed forward. Some are sort of in the middle. So breaking ourselves and our work into teams that are appropriately sized with continued intercommunication can lead to ultimately coming together at the end to have the ability to do the work, measure it, and continue to sustain that project. Next, please. So let's think about PDSAs. We said that we wanted to work together to prioritize different ideas. We've come together and we've got some data behind it, but now we want to implement one of those ideas. And that's where the Plan, Do, Study, Act comes together. So we're going to do that now. Next, please. And I think as we're doing this, I always think about, the many projects that we've done or I've helped with where we have had more or less success or failure, with each part of these PDSA plans and how it might have affected things differently if we had done this more assiduously. So let's think about planning. So we need to think about who's involved in the test. We should write this down together so that we all have a clear understanding of what we're talking about here. When are we going to have this test happen? And how long? Actually, how long do we plan this test to continue when we plan our PDSA? What obstacles or challenges do we see? And then who do we think needs to know about the test? Who do we want to talk to before and then after? Next, please. As we're doing our planning, we need to think about our measures. So we have the outcome measure. For instance, we talked about what % of people are screened and then linked to some level to care. What are the process measures? So for example, one process measure would be Are we doing the screening? That would be an important process measure. But understanding the numerator and denominator for each of the PDSA cycles is very key. And then finally, really in regard to safety, in many cases, the balancing measure. If we do this, then what's dangerous? When we were implementing Lovenox for prophylaxis for our patients, there was a lot of concern that we would lots of patients who would be returned to the OR for bleeding. Very valid question. We measured that, and then thankfully that wasn't a problem, but it was really important to check that balancing measure for our team as we moved forward in that particular process. Next, please. Next, we want to think about piloting. How are we going to do this in a small space? Do a pilot that minimizes risk and facilitates learning. You can do it quickly in the real environment outside of the planning space that we're all sitting in. As much as we think we have a great idea, it's good to actually test it in the real environment and really start to look at it makes you really think about what are the tests that we want to do? How do we get that data? And how are we going to organize it? Next, please. In the pilot, we want to make sure that we have a willing volunteer. We want to think about really limiting, again, what we're doing to the number of locations and people that this affects. Pick something that's easy. It's great. We'll always say, try to get a few wins in the beginning. Get data that actually is meaningful to you as a process team, as well as to the people who you work with. And then be prepared to change. Like, don't get so bogged down in thinking this is the perfect idea. Be ready to change. See this as a test. Next, please. When we look at our data, we want to collect not just quantitative data. I love quantitative data, and even small quantitative data can be very helpful. So if I told you that we had 5 people in X morning who were supposed to receive the screening tool and get it back to us, and 0 of them did it, that's very valuable. If I told you it was 5, that's also very valuable. So even small quantitative data, small numbers in quantitative data can be very helpful. And I think the qualitative data can be incredibly valuable as well. So we've learned a lot as we've rolled out, for instance, improvements to our cesarean timing, or recently when we were implementing JADA, we learned a ton from people qualitatively, not just quantitatively from the process. Next, please. In this case, they're watching the process measure of number of % of screens completed at the initial OB visit by week. And you can see as you're watching this on a run chart as it moves along, how important that is, or how valuable this would be to see when we do X, what happens to that number. Next, please. Always remembering at the end of the PDSA cycle, we want to use one of the 3 A's, adopt, which means basically this worked. We've tested it a couple times probably, and it seems to keep working. Adapt, which means, maybe part of the process wasn't working. We need to fix X, Y, or Z, but let's do that. Or abandon, particularly if something is found to be unsafe or very inappropriate in the space that you're working. Might be wrong. It would be wrong to continue. So that would be abandon. Next, please. Quick nugget on run charts. Next, please. While run charts are really interesting, and we just saw one on the screening process, they can really be, they can also help inform you whether or not to a value of less than p.05, a p-value of less than 0.05, whether or not you've actually caused the change that you see. So when you're getting your data, you can use data continuously for each patient who comes through, or you can use random sampling data. For instance, if you're interested in blood pressures at prenatal visits, you're not going to use, most likely not going to use every one, but you can sample during the day to get your data for your run chart. You can calculate and just use a median for a while, and then you can start to use means after you have 10 is the general rule. But we'll go on to the next page to see some of the rules. So here's a run chart, and you can see where PDSA cycles are interjected to see what happened with each one. Next, please. And then you can actually use these charts to actually say, for instance, this was a cause. So if you look at the left and you see a shift, where your run data shows greater than or equal to 6 points above or below the median, then those are changes that are actually attributable to what you were doing. Next, please. Post-PDSA cycle, so what's next? Again, we talked about the adapt, adopt, or abandon. So once we're done, we really need to think about that as a team and start to adjust ourselves for our next PDSA cycle. Next, please. Remembering always to stay on goal. It's very easy with these process improvements to find one problem, and then you go down the rabbit hole of going to a different project. Because this oftentimes will reveal areas that also need to be improved in your system. But try to stay on goal, stay focused on the process that you're trying to improve within the larger goal, in fact. So modifying the individual test of change is good. The original PDSA cycle likely did not work. We learn more from failure than from doing well. And so basically, let's move to the next slide. We need to keep thinking about what we've learned. Maybe we need to change our aim. Maybe we need to change a process. Maybe we need a process that we didn't even think about. Let's think about all that as a team. Next, please. And then also bringing back, again, that qualitative side to our work. Always make sure that we are letting our teams know what happened. Again, is asking for more information. Boards where we put the PDSA cycles up can be helpful. We can have rounds on this. We can have quarterly QI meetings, for example. All sorts of ways to let the teams know what's going on and try to elicit more feedback and understand their interpretation, including interpretation by our patients who we've been able to enlist, can be so valuable. Next, please. All this is to understand that PDSA cycles operate not just individually, but are meant to add on to each other, improving scale and scope. And we're going to talk about scale and scope in just a moment. But the goal is that we actually, as we do this, we can take a small idea, test it in a smaller space, and then improve both by volume as well as in a significant number of different environments. Next, please. So tips: don't abandon too soon. Don't just give up if something didn't work, because it might have been a problem with execution. Maybe one of the processes within that wasn't working. Again, try to break it down, understand which are the processes and how are we doing. Don't adopt too soon either, just because you had an outcome. Sometimes that can be lucky. Particularly if you are going to try to scale it up or increase the scope using it in different environments, don't adopt it until you know that it works in all those different on volume and different spaces. And then also don't just repeat. I feel like I'm probably the most guilty of this is, oh, it didn't work. And then it's something, we just didn't do it right. And so don't do that if you can help it. But think about what needs to be changed. Next, please. So ultimately, and I will let Dr. Haider talk in 1 second. I just want to say thank you to Kaylee and to Brooke for helping put these slides together. And to all of you, good luck. Please let us know how you're doing. We have a large group of collaborative folks here on this call and within the whole system. And we love to think about how to help you, learn from what you're doing, increase the scale, increase the scope, and bring even more positive change to your patients. So thank you very much.
Thank you so much, Ron. That was wonderful. Everyone will be sharing these slides as usual in case you didn't catch some of the details. You'll be able to look at them later. And if you have any questions for Dr. Iverson about anything QI related, feel free to put in the chat or you can email me separately. All right, now we'll turn it over to Dr. Haider.
Great. Hi, everyone. Thanks, Ron. Your sessions are always so informative. I love that. So Hi, everyone. Looking forward to being here with you today to discuss assessment and illness severity. So, today's topic will be perinatal mental health with a focus on assessment and illness severity. Next slide, please. So, as an overview, I'll discuss a few clinical pearls of mental health and pregnancy. Then I'll take a deep dive into the assessment and illness severity. We have done a presentation screener in the past, so I'll go through that relatively quickly, but I'll look into how you can actually do a full assessment for perinatal depression, anxiety, bipolar affective illness, and other perinatal mood and anxiety disorders. So, as we know, perinatal depression is the most common complication of pregnancy. And perinatal depression affects as many as 1 in 7 perinatal individuals. Now, the highest risk time for most perinatal individuals for mental health disorders really revolves around childbearing. So, for example, averaging across populations, 1 in 7 or 15% of pregnant and postpartum individuals experience perinatal depression. Now, in some populations, such as socioeconomically disadvantaged and adolescent populations, the rates can really be as high as 30 to 40%. Next slide, please. And so, what we know is that mental health conditions are now the leading cause of maternal mortality in the US by 23%. So, this data is from the 2017 to 2019 Maternal Review Mortality Committee. And what it shows, as you can see in the orange highlighted box at the very top, is that mental health conditions are almost 10% higher than any medical cause. Now, the highest was actually postpartum hemorrhage at 13%. So, what this graph shows here is that according to the Maternal Review Mortality Committee data, 23% of maternal deaths in the US are in fact due to mental health conditions. And perinatal mental health and substance use disorders are clearly a leading cause of maternal mortality. And this is driven by both suicide and unintentional overdose. Now, in prior data, when they looked at this data, they actually found that 100% of it was shown to be preventable. So, this is really important data here. And I'll also add that the data for people of color among individuals who have been marginalized or oppressed in general is that the rates overall appear to be higher and the rates of treatment are lower as well. Next slide, please. And so the perinatal period really is ideal for the detection and treatment of mood and anxiety disorders. Now, the American College of Obstetrics and Gynecology, ACOG, which facilitates the Alliance for Innovation in Maternity Care, AIM, re-released the Perinatal Mental Health Bundle, the AIM bundle, and recently released their first clinical practice guidelines, often referred to CPGs, for maternal mental health, and it includes recommendations on screening, assessment, diagnosis, and management of mental health conditions, including bipolar disorder, postpartum psychosis, and acute suicidality. And so we also know we've discussed through PNQIN that the whole mental health care pathway really includes screening, assessment, timely initiation of evidence based treatment, metric based treatment initiation, and follow up to remission, and how this can all decrease the impact and incidence of perinatal mental health complications. And so, again, for this presentation, I'll be focusing on the assessment and illness severity. And at the end, I'll also offer additional resources like MCPAP for Moms and Lifeline for Moms Toolkit, which can really help visualize that whole care pathway full circle. Next slide, please. So again, screening for perinatal substance use disorders and social determinants of health is also recommended. So ACOG says that the guidelines per ACOG say screening at initial prenatal, then again at 24 to 28 weeks, and then again at delivery with a self-reported screening tool, although that timeline postpartum at delivery is not exactly defined. And we also want to screen for structural or social drivers of health. And as Ron had referred to, had mentioned in his talk, screening needs to be coupled with adequate systems to ensure accurate diagnosis, effective treatment, and appropriate follow-up. And we know if those structures are not in place, the data shows it can really, it's really not beneficial and can even be potentially harmful when someone screens positive and nothing is actually done about it. Next slide, please. So I'll go through these relatively quickly, but just as a refresher, the Edinburgh Postnatal Depression Scale is a validated depression screening tool for use in pregnancy and the postpartum period. It's 10 questions. Number 10 looks into self-harm. There is an anxiety subscale, number 4 and 5, that touches on anxiety, validated in all perinatal populations, available in over 40 languages, really easy to use. Next slide, please. Now, the GAD-7 is a validated anxiety screening tool for use in general and perinatal populations. Greater than at least 5 is a positive screen, validated in general and perinatal populations. I'll just quickly add, I'm often asked, if I only have time for one screener, do I do the EPDS or the GAD-7, which is really going to get into anxiety? And I would say EPDS is a good place to start because number 4 and 5 can look at that. If that's positive and you have time and you can explore with the GAD-7, that's great. Next slide, please. The Mood Disorder Questionnaire, MDQ, is a self-administered screen for bipolar disorder. It screens for the lifetime presence of bipolar disorder. It's validated during pregnancy as a sensitivity and specificity of 89 and 84%. Further clinical assessment with a perinatal psychiatrist is indicated. And next slide. The PC-PTSD is also validated in general and perinatal populations. Greater than or equal to 3 yes responses is a positive screen. And now we're going to jump into the assessment and illness severity in detail and what that actually looks like and how we can do that. So to assess for the presence and severity of perinatal mental illness, we want to ask the following questions. So we can look at recent stressors and then previous stressors. So recent stressors include the duration of symptoms. How often are your symptoms occurring is a question we'll often ask. Are you feeling hopeless or helpless in any capacity? How many days are you feeling hopeless or helpless? Now, data consistently shows that of the neurovegetative symptoms, really inquiring and understanding the hopelessness and helplessness that a patient feels is a really strong clinical indicator for perinatal mood and anxiety disorders and perinatal depression. So we really want to get a clinical feel for where they are in feeling hopeless, helpless. Is it difficult for them to carry on their activities of daily living? So I think that's an important clinical feature. Current treatment, whether it's medications or therapy, are they being treated with anything right now? Are they seeing someone? Are they connected to a mental health care provider, whoever that may be? A previous family psychiatric history or a current a family psychiatric history. And in terms of previous stressors, previous symptoms, any previous suicide attempts, past psychiatric treatment, have they been treated with medications in the past? Have they been connected to a therapist in the past? Have they done therapy? Previous psychiatric hospitalizations, current suicidal ideation plan or intent, I think always needs to be asked no matter what, even if you don't clinically suspect it, even if patient is not alluding to it in any capacity, we always just want to ask where they are and have that discussion and document that as well. Next slide, please. And I'll also add, just for the last slide, pages 33 to 35 in the Lifeline for Moms Toolkit expands on that last slide I just showed in more detail. And that toolkit is for perinatal mental health conditions, and I will link it at the end of this presentation. Now, what we do know is scores on screeners correlate with illness severity. That is key. But further clinical assessment is needed and indicated. Now, feel free to screenshot this. This is also in the Lifeline for Moms Toolkit. It'll be on the slides available. PNQIN will post these, but this is a really good summary of all the screeners and how we often categorize them in terms of thinking of perinatal mental health conditions and PMADs. So mild, moderate, severe, keeping in mind that symptom severity directs treatment intensity. And I'll get into that a little bit, but we're going to focus on this on the symptom severity for now. So generally for EPDS, 10 to 14 is mild, PHQ-9, 10 to 14 is mild, GAT-7, 5 to 9, PC-PTSD, yes for less than 3 of those questions. For moderate, EPDS 15 to 19, as well as PHQ-9, GAT-7, 10 to 14. Excuse me. PC-PTSD, yes for greater than or equal to 3. And for severe, the cutoff, I think that the key thing to just remember is the cutoff for EPDS and PHQ-9 is 19 or above. The EPDS is out of 30, so 19 to 30 is going to be considered severe. GAT-7 greater than or equal to 15, and PC-PTSD, yes for at least 3 of them. Now, I will add here, at MCPAP for Moms, one thing that we implemented for the first time this year is that cutoff score of EPDS of 19, because that indicates severe illness, and therefore medication treatment is most likely and is strongly warranted and should be discussed with the patient. And so for calling providers from obstetric practices who call the program, who call MCPAP for Moms, whether it's about resources or they want to connect patient with a psychiatric prescriber, or with their local PSI group or chapter, whatever the question is, if we hear that a patient, if an EPDS was done and it was 19 or above, or a PHQ-9, we would encourage them to talk to one of our psychiatric consultants, because medication treatment is indicated for 19 or above. It really means the patient should be treated. So just wanted to share that that's an important number. Next slide, please. And I'll also add it's for EPDS 19 or a positive 10 on the self-harm of the EPDS, because we would want them to have a discussion with the consultant. Now, going into the severe box from the last slide, just to elaborate on this further, because it's so important. It's a depression screener of over 19, a GAT-7 of greater than or equal to 15 to 19, PC-PTSD, score at least 3, suicidal ideation, intent, and or plan in any capacity, previous suicide attempt, patient often on a near daily basis or daily basis feels hopeless, helpless, or worthless, a history of multiple psychiatric hospitalization, patient often feels unable to care for self or baby, maybe act floridly psychotic, may experience hallucinations, delusions, disorganized behavior, altruistic delusions, or any other psychotic symptoms, for example, in the setting of major depressive disorder with psychotic features, or postpartum psychosis, bipolar disorder with psychotic features, and if patient has had a history of multiple medication trials. Next slide, please. And so we've done our positive screen. We've assessed for severity and comorbidities. And I think just keeping in mind, just repeating myself, but this is important, scores on screeners do correlate with severity. And so then we can discuss and look into treatment and support options, which I'll touch on the next slide briefly. So we want to consider treatment options based on the highest level of illness severity. Now, all patients who screen positive, regardless of illness severity, should be referred to therapy or be advised or encouraged to continue therapy. And so I think being in touch with a mental health provider is really the key thing here, regardless of illness severity, even if it's for mild illness. And if the severity of symptoms overlap, clinical decisions should be based on the assessment with strong consideration of higher level treatment options. Now, for mild, moderate, severe, a therapy referral should be considered or recommended in all cases in MCPAP for Moms. If you're an obstetric outpatient practice, can certainly help with that. We have a great team of resource and referral specialists that can really specify the type of therapy referral based on patients' needs, their insurance, virtual, in-person, different types of languages, really anything that you can think of. And so that's a potential resource. Now, for mild, you can consider medication treatment, especially if the patient wants to be on medications. And for moderate to severe, moderate, you strongly want to consider medication treatment, and severe, you most definitely want to. This goes into brexanolone. Brexanolone is IV. It is not offered in the state of Massachusetts. Zuranolone, the PO version of brexanolone, is offered. It's something that I have prescribed a few times for several of my patients with very good clinical effect. I would have to say for those patients I prescribed it to. Zuranolone, SSRIs, all are great options. Feel free to call MCPAP for moms, and we can certainly discuss with you. Next slide, please. So the next two slides, we have 5 minutes. I will go into assessing the risk of suicide and assessing the risk when a perinatal individual, a parent, says that they are having thoughts of self-harm to the baby. And then I'll link to some resources as well. And so when we assess for the risk of suicide, this is in situations where patients report thoughts of self-harm and or there's a positive self-harm question on the EPDS, PHQ-9, any response other than never. You want to follow the EPDS or PHQ-9 positive self-harm with patient safety screener, a suicide risk screener to further stratify risk. And in terms of risk, we categorize it as low risk, moderate risk, or high risk. Now, I will say as a summary here, this is a really exhaustive chart from the Lifeline for Moms Toolkit. Again, feel free to screenshot and my slides will be available. But we always want to ask in any situation when we're doing assessment or illness severity to really ask about the thoughts of self-harm or wanting to die. Sorry, was there a question? And so thoughts of death or self-harm are common among individuals with perinatal mental health conditions. Now, things that I may start to say to my patients to assess for risk are, many people have intrusive or scary thoughts. When people are sad or down, they often have thoughts about death or not wanting to be alive or just wanting to die. And these thoughts can feel really awful. They can sometimes feel reassuring or like an escape for a very hard life or something else that just feels too hard to bear. So I just want you to know that I'm here to help you. And we ask about these thoughts because they are so common. So that could be a potential conversation opener that I may have with one of my patients. And now I think just for the sake of time, what's really important here is for high risk, the patient is having persistent daily thoughts of death or life is not worth living. There is a current intent, a current well-formulated plan, in addition to potential previous history of multiple suicide attempts, especially high lethality, history of multiple recent psychiatric hospitalizations. Whereas for low risk, there's no current intent or plan, and they may have passive or fleeting thoughts of death or wanting to die. Next slide, please. Now, when we're assessing for risk of harm to the baby, I think what's important here is that unwanted or intrusive thoughts, including those harming the baby, are actually very common, up to 70%. Most of the referrals to me in my women's mental health clinic at UMass are really thoughts of self-harm to the baby in the context of OCD or anxiety. And so I reassure patients it's up to 70%. Less than 1% of the time these thoughts are in the context of postpartum psychosis, but it's such an acute, it's such a psychiatric emergency that we really have to be on edge for that. And our next webinar will be on psychiatric emergencies, and we'll talk about postpartum psychosis, but just want to share that statistic with everyone. And so most of our patients are not going to act on these thoughts because they're usually due to the anxiety or depression or OCD. But it's very different than thoughts of harming the baby that are due to altruistic delusions or actually postpartum psychosis. So thoughts that I may ask my patients are, things I may discuss with my patients are, people will often have these intrusive thoughts or thoughts that may seem to pop into their head from nowhere. And patients often have these thoughts about something bad happening to their baby that they can't control. And these thoughts feel so awful. And it may sometimes feel like it can be an escape from something that's just hard too difficult to bear. Can you tell me more about these thoughts? And I just want to reassure you that oftentimes it's most likely, anxiety. And then you really want to get into, are you having actual thoughts of harming the baby and harming the infant? And how often do you have them? Are you scared by them? The key thing is, for thoughts are actually that are low risk. The thoughts of harming the baby are very scary to the patient. The patient may feel very ashamed to even share with you, but she makes it very clear that she would not harm her baby in any capacity. These are ego dystonic thoughts, whereas for something that's high risk, the thoughts of harming the baby are comforting, and they may actually want to act on these thoughts, and these are ego syntonic, and the patient is floridly psychotic, disorganized, and that's a psychiatric emergency, and patients need to go to the ER. Next slide, please. So in just about 30 seconds, MCPAP for moms is a great option. Next slide. If you have any questions about assessment, clinical formulation, a consultation, a face-to-face assessment, we can talk to you. Really do a risk stratification. We're here to guide you. This is a great list of resources that we like to share. The behavioral health helpline is a great option, 24/7, 365 days a year. Open when MCPAP for moms is not, because we are 9 to 5. And then next slide, please, the last slide. And these are a few links. The Lifeline for Moms Toolkit is here, as well as links to ACOG and the CPGs and the bundles. All right. Thanks, everyone, for having me. It was great to be
Thank you
here.
so much, Dr. Haider. I know you needed to leave right at 1. So what I put in the chat, everybody, if you have any questions for Dr. Haider or Dr. Ron Iverson, please put them in the chat, or you can email me at pinquinadmin@pinquinma.org. I'll put that up on the screen for you. We'll be taking questions from the chat or via email, and we'll reach out to both of our presenters and get answers for you. Sorry we are running a little bit behind today, but we thank our presenters so much for their wonderful presentations. Again, this has been recorded if you'd like to go back and rewatch any parts of it, and the slides will be on our website as well. So thank you, everybody. We look forward to seeing you again on February on the 18th for our psychiatric emergencies webinar. Hope you all stay warm out there.